All right, let's get going. So welcome everybody. It's great to see everyone again. Even though I can really see you, but it's great to really be hosting this NovoPath Experts Speaker Series again. This is has been a staple for us here at NovoPath, and it's something that we really enjoy doing, and we take a lot of pride in the ability to provide a platform for the thinkers and the great leaders in our industry to be able to share their learnings and experiences with all of us who are the market stakeholders. So thank you everybody for joining and for making the time here. Today we have a very interesting and exciting series. We'll be talking about the future of diagnostics, AI in action. The goal is that you come out of this learning how AI is really transforming laboratories, transforming accuracy, efficiency, and patient care. We've always been believers in empowering laboratories with the toolkits to have a transformational patient care, delivery. And we've got a great speaker who will be helping us really digest, dissect, AI in action in the pathology lab space. Her name is Dr. Bowie. Dr. Bowie is a renowned pathologist. She is a senior member and professor at the Department of Pathology and Machine Learning at Moffett Cancer Center. She's also the chair of Digital and Computational Pathology Committee at CAP. She's an author of over 200 plus peer-reviewed articles. She's written multiple book chapters, and has multiple patents. She has received the CAP Distinguished Patient Care Award, Educator of the Year, and multiple presidencies. She's been featured everywhere, including the most recent publication of the CAP Today. So be sure to check that out. It's on the CAP Today website. So if you have the most recent edition of the magazine, you should see her interview. It's also, if you had gone to the most recent DPA conference, she was also she was featured on the magazine that was distributed there a couple of weeks ago. So Dr. Bowie, thank you so much for for being here, and we are all really excited about, I know when we're going through the our conversations about this webinar today, it left me quite excited about the different things that you guys are doing already, and I think our audience has a lot to learn today, and I'm really excited about the conversation. I think there's a lot of energy in the room for sure. So we're gonna go through the agenda for the rest of today. We'll talk about the AI's impact on day-to-day diagnostics. We'll also talk about how the pathologist role is being enhanced by AI. I know some people, early on, about 5 years ago, folks were afraid that maybe AI is going to take over pathologist jobs. And we really don't think so. We don't see it. We actually think that pathologist jobs will be made a lot easier, a lot faster, more efficient, more productive because of AI. So she's going to walk us through how AI and how she's used AI and how that's really enhanced her experience and pathologist experience. And then the third piece is we're going to go through what it means to build an AI-ready laboratory in 2025 and beyond. And then we're going to have Q&A at the back end. Before the Q&A, we have a little nice surprise for everybody. We love surprises. We love a nice surprise. So please stay around for the Q&A, because we have that nice surprise for everyone. But without further ado, let's get started. Dr. Bowie, the floor is yours.
Thank you, Promise. Congratulations on NovoPath in leading pathology diagnostics and pathology education. So this platform is really fantastic. Brings pathologists, scientists, administration, and business people all together to understand the current trend in pathology and the pain points. How can we work together to solve it? So this is really great. I also want to thank your team, especially Beth and Amber, who has been working with me tirelessly and bring this webinar to you guys. And I'm very excited for this opportunity, and I hope everybody will enjoy this. So we're going to start with, it's very exciting to practice pathology right now because we're experiencing the third revolution of pathology. So that's digital pathology and AI. Our profession was born with microscope, HE slides. So we're able to study cells at the cellular level. That was fantastic. Our first revolution was immunohistochemistry. These brown stains give us the ability to study the proteins, biomarkers at the cellular level. So that's the very beginning of precision medicine. We all remember the role of ERPR HER2 in breast cancer, later on GIST, CD117. So the next revolution was molecular pathology. We were able to study disease at the genomic level. So that gave us really open up the door for precision medicine. The biomarker is just emerging. So pathologists become really, really powerful in the center of leading precision medicine. But once this is evolving, then we realize the traditional pathology, that is eyeballing, the morphological interpretation is limited. So we need to expand the pathologist's role into precision medicine. We have NGS, but the human's recognition has limitation. But with NGS, with all the explosion of information, we need the systems of computational pathology. So that's how digital pathology and AI is coming in to augment our ability to continue to take the leadership role in precision medicine. In the next slide, and we will show digital pathology solve one big problem. And if you click on what the next one, we will see right now we're experiencing shortage of pathologists worldwide. In US, you can see some green, but in other part, you will see like a deep red. That means really, really short of pathologists. In addition to that, the disease is increasing because people are living longer. So cancer is rising. So there are shortage of pathologists, but we're in the center of diagnosed diseases. So in the next slide, we're going to show. So the first function of digital pathology is to connect us all, connect pathologists with all the cases across the imaging system. So that's the number one role of digital pathology through remote consultation, frozen section, rapid on-site evaluation, and reports. But the most important role of digital pathology is in the next slide. It is the foundation of computational pathology and AI, because AI is a branch of computational pathology, attempt to do what's human is doing, but have the ability to empower it. So the next click will show, and this is what I'm talking about. So human cognitive capacity, if you're just eyeballing it, really have the limitation. So that's the yellow line drawing here, right? You can see that. But when you add all the information, proteomic, genomic, and functional genomic, and the tumor environment, all that factor together, we really need assistance of computational pathology. In the next click, we're saying that traditional pathology using just the HE and eyeballing is analog. It's only scratching the surface of the data. But with the computational pathology, we can really provide powerful information for patient care. Because as a pathologist, we have three roles. First is to provide diagnosis. Second is provide prognostic information. The third is to provide predictive information. So this is really important in precision medicine era. So, Promise, do you have any questions on these concepts of digital pathology and AI?
No, I think this is a great foundation. Thank you.
All right. So in the next slide, and I just want to emphasize when we talk about AI, people tend to use artificial intelligence. I don't like that concept because on the left, it's showing it's a robot is doing what we're doing traditionally, and then the robot may replace us. So let's throw away this concept and look at the right. It's a very empowerment type of image. The pathologist is in the center, not just pathologist. Pathology and the laboratory medicine is in the center of patient care. And because we're speaking a digital pathology language, we're in the digital health ecosystem, so we can leverage radiomic, proteomic, genomic, and outcome data to really empower us to do more and better for pathology. So I like to use the term augmented intelligence whenever we mention AI. So now we're going to talk about how pathologist role can be enhanced by AI. So there are a lot of applications. So I am organizing these applications into 3 main framework. One is to augment precision pathology. It's more in diagnosis and biomarker prediction type of information. The second framework is workflow and quality improvement. The last one is impactful reporting. As pathologists, there are a lot of pre-analytical work, and then we do a lot of analytical work, and then we put everything into a report. And this is a very powerful piece of document because patients will read it, the clinicians will read it, everybody will take action on the report. So right now, it's just a paper form, PDF, but in the future, there are a lot of other multimodal and the interactive type of reporting that really have the patient in the center of the reporting. But with the time today, we're only going to focusing on the first framework, that's precision pathology. So in the next slide, I'm going to show there are 5 categories of applications in precision diagnostics. The first is detection. The second is classification. The third is quantification. The fourth is prognosis. The last is prediction. Let's talk about the detection. Finding tumor cells, it's a big deal. So that's the first step of what we do. So even in 2016, the US government already realized AI is really powerful in cancer diagnostics. So this is the example of finding metastatic breast cancer in sentinel lymph node. So the data showed the top AI system had error rate of 7.5%. The top specialized breast pathologist has error rate of 3.5. But when you combine them all together, it's reduced the error rate to 0.5%. In addition, there is induced proficiency. So take another click, Amber. So this is the type of patient care that our patient really deserves. So this is a much more recent study in Europe published in Nature Cancer using AI detect metastatic cancer in breast. So this is a big use case. There are a lot of study has been done. I'm only highlighting one study because this study is showing with AI, we can reduce the usage of immunohistochemistry to look for metastatic cancer cells. So this cut down the waste of additional section, additional IHC, and the sensitivity and specificity is really high. So that also improve the turnaround time because I know We all know the IHC takes overnight, right? So then in long run, and this is really better for the patient, better for the economy, and also better for pathologists. So this is one use case of detecting breast cancer. And when pathologists find the cancer, our next step is to classify. You know that we have like 4 major type of cancers. The epithelioid cancer, so that's the carcinoma, the breast cancers, the lung cancer, squamous cell carcinoma, they're all in that category. That's the most common type. The second type will be melanoma, the skin cancers, especially in some areas like Florida. Melanoma is really has a higher prevalence in places like Florida. The third big category is hematopoietic malignancy, the leukemia, the lymphomas, and plasmacytoma, multiple myeloma. The last category is sarcoma. It's rare mesenchymal tumor. So when we find the cancer cells, we need to put them into classification. Now, the classification become a lot more subdivided because our understanding of disease is much better now. So when I was in training 20 years ago, lung cancer has only 2 diagnoses, non-small cell carcinoma and small cell carcinoma. So the treatment was totally different. The non-small cell has a certain chemotherapy, and then the other non-small cell, you just treat them with surgery. But now, in the era of precision medicine, the diagnosis of lung cancer is really advanced. So when you know it's non-small cell, we need to classify into adeno, squamous, polydifferentiated, and other type. And with each diagnosis, there are certain biomarkers associated with them. With all that information, the clinical team now can decide what to treat. So to help pathologists to be able to accurately classify the tumor is really important. So this example is developed by a researcher I'm involved. Pathologists and machine learning scientists will collaborate together. We can classify bladder cancer. In the next example is you use AI to classify sarcoma. So the third category in this group is the quantification. So this is a most invested area for AI because for biomarker testing, we all know they're not just simple IHCs, just talk about positive, negative, and it's not enough. And we have to know a certain quantification where the cutoff is. So the HER2 low, HER2 ultra low, the PD-L1 present unique challenges. So this is the area that there are a lot of investment and application. So I just want to give you an example. This is multiplex testing. On the left is a lung cancer, and you can see the cytokeratin highlights the lung cancer cells. All the other markers are immunomarkers. With that information, the medical oncologist will know if the tumor will be responsive to immunotherapy or not. On the right hand, it's a melanoma. The tumor cells are highlighted by SOX10, and all the other markers are highlighting the immunoenvironment. So this is a very simple example to show eyeballing is no longer working. We need a computational pathology to do quantitative image analysis, or we use AI to do study to be able to help us to identify the interpretation of these biomarkers. So in the next slide, go back to the slide here. I'm just showing you, this is the most invested category. So this is borrowed from College of American Pathologists. If you're a member, you can access to this. It's called the AI Studio. If you go to aistudio.cap.org, this is new to bring the AI apps together to showcase pathologists how they work. So on the right-hand side, I'm showing an example. In this vendor, they have 20-some apps just to quantify all the biomarkers, the common ones, the ER, the PR, the CD markers, the Ki67. So I want to show you in the next slide, we're moving into the next class. So these are the AIs for prognosis and prediction. Prognosis is to show the behavior of the cancer. The prediction is to show if the patient will be able to respond to therapy specific to certain biomarker. So this multimodal biomarker testing is for prostate cancer. It's recently FDA approved. So it combines the HE information, the ER/PR information, and the clinical outcome. And then the AI is specifically can predict if the patient will respond to certain therapy, the hormonal therapy, or they should be treated conservatively, or they should be treated for surgery. So let's click on this app, open it up so I can show you it's AI in action. Here we go. Let's click on Altera. And let's click on the patient, Adam Anderson. So this is just for education. It's not a real patient. It's a real patient, but the name has changed. So this little wiggly worm-looking thing is the core biopsy of prostate. So let's click on any area of this. Click on it and enlarge it. Enlarge it. Continue click. Continue click. Now we can stop. And there are prostate cancer cells on this slide. So for pathologists to diagnose cancer, we look at the following things. First, we look at the nuclear features. The nuclei are stained by hematoxylin, so they are purplish, bluish. Malignant nuclei are enlarged, irregular, and they look dark and ugly. So they're big, dark, and ugly. In this case, we see the prostate cancer nuclei. Second, we look at their architecture and how they arrange. This is very infiltrative. The last, we'll look at what they produce, what kind of matrix they produce. In this case, the mucin, they have vacuoles, so they're producing mucin. So we call them adenocarcinoma. So then how the clinical team should treat this. So let's click on the AI result. And then let's view the report. So the AI is showing the 10 years risk of distant metastasis is high. And then the interpretation is less likely to benefit from certain therapy. And then the clinical team with this information, they can treat the patients. So this is very powerful, just to show our collective work from the clinical team to obtain the sample, coming to pathology team, we process it, we make the interpretation, and then we make this reporting is really benefit patient care. So we talk about all the applications now. Promise, do you have any questions or any comments?
No, I mean, I think this is great, just being able to just see the tools in action and how that's really enhancing the pathologist. I guess the pathologist workflow. I guess my, first quick question I have for you on this is, from your experience, obviously you see the tool giving you the report and some sort of prediction, to guide your diagnosis. How does a pathologist, or maybe this is some bias that happens where the report shows that, hey, there's an 80% probability that this is this patient might actually have melanoma. Are you mostly relying on what the AI report gives you, or are you also using your experience as a pathologist of having done this for, in your case, for 20 years to maybe override or kind of support the ancillary work that the tool has done for you?
So great question. In my mind, there are two big type of AI. One is the more basic, simple task. So this is just using more data to do what pathologists usually do, then give you a prediction. So for that type of test, human in the loop is really, really important because AI is a tool. And for us, we're pathologists, we're physicians, we look at that data point, but we also put together all the clinical information and how put everything together. So we override things that is obviously wrong. So in this case, the interpretable AI is really important. So we can, for example, if you're reading a pap smear and then they're showing you 20 tiles to confirm their diagnosis, you could at least investigate if they choose the correct cells. If they are, then you have more confidence in it. And if they apparently pick the wrong cells, then you should override. So human in the loop is really, really important. But once the AI become more sophisticated, so what AI trained on, not only the morphological data, the immuno data, but overall the genomic data and outcome data. And then the pathologist supervision, it become challenging because the reason we are asking the help from AI because we have a cognitive limitation. If we are overwriting something that is doing better than we did, then that's against innovation. Just like you remember the story using computational tool to compete with human on that chess play, the Go game. At the beginning, human beat computer, and then the computer gets really smart. The computer start to defeat human, and then humans start to study what AI is thinking, and human is able to come back to do better. But then computer also becomes smarter. So it's this collaboration will continue to push us to the next level. So at a certain point, the pathologists need to be open-minded, that at a certain point, they're not replacing us, but there is this collaboration need to be taking place.
Thank you.
In the next slide, we're going to go to the question is what that means for the laboratory now, right? What means to build an AI-ready lab in 2025 and beyond. So I just give you one example because I collaborate with them, I'm familiar with them, so I feel confident that I could talk about this without misrepresent them, and I also have the permission with Dr. Lu to talk about it. So this is a reference lab in Chicago area. Their company is NovoPath, and they branch out this digital pathology branch called the Digit Cells. So it has this complete solution for the reference side. When patients' data and biopsy comes in, they have a way of optimizing it. For example, if the GI biopsy or prostate biopsy, the traditional way is to put that single core by the interventional radiologist into a formalin jar. If they do 12 core, they're going to have 12 jar, and this jar will come to pathology. And the pathology, the PA will open it and then grows it and then put into the cassette. The cassette will go to histology and go to downstream processing. So they revolutionized that. First, when the interventional radiologists take the biopsy, they put into a barcode special designed cassette that has 3 cores in it. Each one is barcoded. And then all these 12 biopsies will put in 4 cassettes, and these 4 cassettes will get into one corpulin jar. And this jar, well, formalin jar, and this jar will transport to the pathology, bypass the VA, go to histotech. On a station, it will have automatic grossing, and the AI can use the camera to measure, dictate, and then these cassettes will go to the processing straightforward directly. So you bypassed time, you cut down the manpower, and you cut down the material usage. And also you get ready for digital workflow. So when it's scanned, and the case can be automatically assigned to people, and the AI can have algorithm to control the quality and also scan certain things to alert additional biomarker testing. For example, if breast cancer is detected, we all know that all breast cancer for primary diagnosis need to do ERP or HER2, all these biomarkers. So you just improve the workflow. So this lab will process this and then use digital pathology. The information will go through cloud to go to the people who ask for these services, and then the pathologist can sign up cases. But if you are in a place that you need subspecialty consultation, for example, in my cancer center, we do subspecialty consultation. And when I am in one location, the frozen section in my specialty happening in that building, and we will do telepathology to help people for frozen section and for rapid onset evaluation. So this whole digital workflow is a total solution to improve the efficiency, quality, case contribution, and also really standardize the patient care, because no matter where you're at, right now, if you come to a multi-cancer center, you have this excellent pathologists, excellent clinicians give you the first class of care. But if you're a patient in a remote area, if you are affiliated with cancer, the care will be the same no matter where you are. So this is a very powerful workflow, and good for the patients, and also good for the economy of the healthcare, and also good for the pathologists, because now you can do more cases and you practice at a higher level of your skills. So in the next slide, and the promise is going to show what's the solution at NovoPath. I look forward to hear about it.
Right. Yeah, thank you. And I think the way we think about this is, as you guys have seen, this workflow, you need to have the right workflow to be able to be ready for AI and harvesting the benefits of AI. And what we do at NovoPath is, we do provide free consultation to laboratories where we come on site and we do a workflow assessment this is complimentary at no cost to you, where we really analyze your workflow, create an assessment of how you're doing things today, and really give you a report at the end of it on, hey, is your lab optimized to benefit from these new technologies? The truth is, in the LIS market, you've got some of these tools and software systems that were built 30 years ago, 25 years ago, when they did the work they needed to do, but they're very old and clunky and just not optimized to operate at with the new advancements in technology and in AI. And people are just trying to make it work, and so they try to introduce AI and through the viewer to work with this really old LIS tools, and it's just a very clunky workflow. If you want to really take advantage of these benefits that we're talking about, I think you need to be thinking about where if your LIS is optimized to operate at the level it needs to operate to get the ROI of innovation that's happening today in the in technology world. So this is again a free solution that we've provided for labs, and the labs that we've gone on site to do this, they've really had a great benefit. Again, we come on site for free, we hope if you're interested, go to novopath.com/workflow, and our team will follow up with you to schedule some time to do this. All right, so before we jump into QA, and please, at this point, we're going to open up the QA, so feel free to start asking questions, leaving, comments. We do want to make sure we accommodate as many questions as possible for Dr. Bowie here. But we have a short video to share with you. As we mentioned, we have a very, very reputable pathologist here with us as our guest, and she's done so many phenomenal work. And this is one of the things she's done, a documentary on her too, that she was featured in, and we'll love to share with everyone. And again, you can, if you want to watch the entire documentary, you can scan the code, the QR code here to watch the full documentary. But we want to share a trailer with everybody.
Breast cancer is the most common cancer in women. 1 in 8 women will develop breast cancer in their lifetime. That means we each probably know someone, either from our family, our friends, our colleagues, is either going through this difficult journey. When we first started learning about HER2 as a prognostic factor, because it's both prognostic and predictive, what we understood was HER2 positive cancers, even if they were little, they were more likely to have positive nodes, for example, than a slow growing hormone receptor positive cancer. And they were more likely to metastasize early. And that's still the case for HER2 positive cancers. But it's, as I tell patients, evolved from being what we understood before we fully understood triple negative disease, the worst subset of breast cancer, to the best. From the evolution of HER2, you can see it really evolves with time. At every point, the medical oncologists and pathologists are working in collaboration to improve patient care. So thank you for sharing this. And so this is made by pathologists for pathologists in the healthcare scientists, technologists. That we combine digital pathology. If you want to practice HER2 interpretation, you can see whole slide images and the education all together. And also there information on HER2 low, HER2 ultra low. So thank you for highlighting this resource. So this is just a gift of education to all, and it's sponsored by 2 pharmaceutical companies.
Fantastic. Great. Well, so we've come to the end of the main presentation. Now we want to move over to Q&A. Typically all of this information and the presentation and the video will be sent out to everyone who is who's registered for the event. Dr. Bowie has been very gracious to give us these resources that we can share with you for your education. So if you have any questions, please drop it in the QA chat. You can get going. In the meantime, one question I have for you, Dr. Bowie. So as you've sort of seen pathologists leverage AI, have you seen that sort of slow down their productivity, or has it seemed that to be an enhancement? Could you maybe share more around the efficiency and productivity as they use AI? So first of all, for digital pathology AI at the initial implementation stage, it will take time to set things up. But from the studies published and from the people who has done this, they all say that after they get used to the workflow, it's such a liberation. They feel like they can do it faster and better. And when I say faster, it doesn't mean that we no longer spend time to it. I would just say you will have more confidence
because now you're not just on your own doing everything manually. You will still do that, but you have a tool that give you as a second opinion to help you with that. So that's most of the publication and the people that we have talked with. This is one. The second is people are having this misconception that we have to wait until our lab completely go digital in order for us to start picking up tools, AI tools, to improve our efficiency. It's not totally true because even you have just a single slide scanner, you can already start to improve your laboratory IHC quality by using, there's this product, it's from Europe, from Visiopharm called Qualitopics. What they do is using the reference material, like cell lines, beads, and the cultured material, you can put it on as a control slide. And this control slide will run side by side with your patient sample and your traditional control slide for your IHC. So when you finish running it, you can put this control slide loaded into cloud using just a single scanner. And then on the Visiopharm account, they can analyze your IHC and monitor if it's within the normal or using this plot, Levy-Jennings plot. If it's outside this plot, and then you start troubleshooting what's wrong with your automated IHC machine. And very often you can find the reagent is expired, the nozzle getting clogged, or some other issue, even the water quality is changed, so your IHC. So this is really transformative because when you go to the clinical laboratory, it's an old machine. You put a bag of sample into the machine, you have the report coming out at the end. It's an automatic system. But when you go to AP, it's still truncated, manual process. And then you put into the scanner, then the machine does certain things. When you come out, it's manual process. But this is one step to monitor all your IHC on a regular basis to improve the quality. Does not even need a full digital workflow. There are other softwares I saw at the Pathology Visions, and the individual pathologist can have this software. When you are going through your slides, the AI is already doing the work that you ask them to do. So when you finish screening your slide, the AI will follow your eye movement and tell you what's the interpretation, what's the IHC. So this type of things, without a fully digital, you can start doing it. Of course, when you're fully digital, it will be easier for you to work them into your workflow.
Absolutely, makes sense. We've got a question here around, staying based on AI algorithms. So, being efficient. One of the benefits of some of these AI tools that I've seen is, you could probably, it can auto order a stain to be prepared. And you mentioned this in your talk, to be performed and ready for the pathologist review. This saves time, but some payers don't want to pay for stains performed ahead of time. So how have you seen pathologists deal with that? How can people maybe even deal with that moving forward?
Well, for pathologists, when you use because right now for digital pathology, we don't get paid for it because the reimbursement codes is class 3. So that means you document the utility and you want to prove this is popular methodology that warrants payment. And then the next step is to grade it to the type 1 code then put a dollar amount, and then get reimbursed. So right now, if you're doing breast cancer, you pre-order IHC, nobody will tell you how it is paid because it's not really in the mix. On the other hand, because this is a medical decision, and your breast pathologist and the clinical team will already discuss that in what situation the specific immunostains will be ordered. For example, the criteria will be first-time diagnosis of breast cancer, biomarker has not been done, right? And then if you can sort that out, and right now, in certain practice, when they realize it's breast cancer, they will cut HE, send it for pathologists for diagnosis. They cut subsequent unstained slides. They will follow that case to the pathologist. When pathologists realize it's breast cancer, they will use the unstained slides to order IHC, will save them some time because now you can do it the same day. So then when you use AI, you're just one step further than that. So I think pathologists and the laboratory should decide what's the best for their patients. And then right now, the reimbursement is not really in the picture. When that
Yeah,
comes
but
along,
yeah, Dr. Boyd, sorry to interrupt. I guess because the question is around really the actual IC staining itself, the special staining, to get reimbursed for the special staining, not for using digital. Obviously at this point, before the pathologist is before the special stain is ordered, the pathologist hasn't really viewed the case yet. But some of this AI algorithm can probably tell which cases should have a special stain and which one shouldn't. And so if the AI algorithm is essentially saying we should order special staining before the pathologist views it, are you seeing pushback by payers that, hey, no, we can't reimburse for that because the pathologist hasn't reviewed it yet? And if you're seeing pushback, how have you seen labs bridge that gap?
so there are two ways you can deal with it. You can follow the rule. You wait until pathologists see it, you order it, or you can do study to show the insurance company how much confidence you have
Mhm.
for the AI to do it, because the AI become your surrogate. Just say AI is your residence or fellow, right? We give authorization to our senior experienced residence fellow to pre-order IHC because we train them, right? So you can do that study to show the insurance company we did this many tests. This is how reliable the AI is. And then let's see if they will say, yeah, even you're not physically seeing it, but your surrogate already have this interpretation. You have a track record of showing how reliable of that is, and you did not waste any healthcare dollar, so we'll pay for you. I don't have personal experience with billing because in an academic center, we have the billing office. And then I don't have personal experience, but if I have to anticipate how to deal with this problem, that's what I would do. You show them the data.
Fair enough, makes sense. I've got one other question here. Maybe we have a chance for another one after that, but we have just one now. One more question here before the hour, which is, we've got labs who want to go digital, but there's a lot of resistance from pathologists. They don't want to change, and I've been in the lab industry for so long. Pathologists don't like to change stuff. And so when a laboratory is and the lab leaders are seeing this push, this resistance against change, but they see the benefit of going digital, applying AI, into their diagnostic workflow. How any advice on how lab leaders can lead this way for innovation, can really push and convince the pathologist or to embrace this change, especially when they don't want to?
All right. So the leadership will first show people the reason why going digital, right? And then on the for the pathologist education, and it's going to be different. There will be a group of them are very enthusiastic, early adopter, and those are great. And there's some people need a little bit of convincing, and eventually they will get on. And there are some people will be resisting. So I can tell you a story. Is this pathologist? She's at the retirement age. Her laboratory decided to go digital. So in that 2 months, she was taking vacation. The lab was fully digital. So when she come back, her choice is either retire or you sign out the digital case like everybody else. So she goes like, I don't want to completely retire, so I bite the bullet. So I start to sign out digital code. Everybody else already had a head start because they had the training and all that. My choice is burning platform, you jump or you die. So she figured it out. And she said, to my surprise, I love it. Now I'm not going to retire because for 3 days of the week, I don't have to come to work. I enjoy signing out cases. I just don't want to go to work. Now I don't. So I get the best of both worlds. She said, I was so silly to resisting it. Now I love it. Real story. So I guess people have to be open-minded. If not, they just have to make a choice because the train of digital pathologists AI has left the station. People already got because the future will keep moving to the future without waiting for us. It's really us to make that decision. Do you get out or you not? All right.
That's great. Thank you. We've got two other questions. The first one is, have you seen AI significantly decrease the use of outside consultation requests? Because labs are now using, at least for labs that have deployed AI into their workflow.
So the adoption of digital pathology is increasing. There are like a greater than 20% of the laboratories are using whole slide imaging for primary diagnosis. But in the reference labs, and there are even higher numbers. So those are the practice survey data from CAP. However, using AI is not as prevalent as it's at the beginning of it. So we can't really predict what's the impact right now because people just start doing it. But what I guess the question is, are we worried about the AI may replace pathologists instead of they send the case to places like Moffitt Cancer Center? They will just use the AI software to help them. Is that a question? Is that about outsourcing? Is that the
Yeah, it's questions around, getting extra consultation, right? Extra consultation on, especially on difficult cases. And so, instead of having to go to Moffitt for a second opinion or things like that, we could use AI to, the pathologists could use AI to enhance their diagnosis.
Well, I think AI will definitely standardize the diagnosis. For example, if you're in a remote place, you don't have the ability to send cases to Moffitt Cancer Center. When you have AI, your AI-enabled pathologist, it will be better than you're on your own. But places like Moffitt Cancer Center has more to offer than just the AI, because not only we're doing standard practice, we're doing cutting edge process. So depend on what you want. You want to standardize, you want excellence and better. So that's you decide if you want to send it to somebody or not. So I do agree AI will elevate you, but the AI is not the only solution.
Well, that's helpful. All right, one last question, which is, let's just zoom out 5 years into the future. Where do you think AI and digital, labs is going digital? Where do you think things will stand 5 years into the future from now?
We will see more adoption because right now, as I said, digital pathology is gaining momentum. This train already left the station. So when people try to get into digital pathology and AI, it's no longer innovation, it's just fear of missing out. So we'll see more adoption. But on the other hand, there are three adoption models. There are academic centers like Moffitt, Mayo Clinic. It's from top down. There's investment, there's a leadership strategy. So that's one model. And there's another model is the department realize that's what they want, but they have to go through a lot of barrier hurdles to get funding from the institution, work with IT. And so that's another model. And the third model is individual pathologists or laboratory owners. They realize the value of it. They invest and then they take ownership. They just go fully digital. So the trend is going to be the one have more control of their finance, decision making will use digital pathology and AI more than the people who have to go through a lot of, cut through a lot of red tapes. The second is we're going to see more of the applications in these 5 categories we discussed, but we're going to see more in the prognosis and prediction type because even pathologists are trying to work very hard trying to be enabler for precision medicine. Very often the perception is it takes too long and all this, all that. So if we don't put our acts together to provide accurate diagnosis, high quality diagnosis, there is a risk that clinical team will bypass us, use AI to go directly to diagnosis and prediction. So we need to be very careful to take leadership role, to collaborate with the industry on everything that relates to patient sample, patient data, because we are the profession that are trained to be custodian of the patient tissue, patient data, and we play a very important role in this. So we need to take leadership role in AI development.
Phenomenal. Great. Well, Dr. Bowie, thank you so much for the time. This has been great. This has been phenomenal. I learned a lot. And I hope that everyone who joined us today also learned a lot. Well, as I mentioned, we'll be sending out the materials for the webinar after the webinar. But thank you so much for the time. Thank you for your knowledge and your experience.
Thank you so much. The disclaimer is everything I said represent my personal opinion from 20 years expertise. I do not represent Moffitt Cancer Center or CAP. And thank you so much for this wonderful opportunity.